Good afternoon, everyone. Thank you very much for having here. So this is a symposium I'm doing around liraglutide. I'm a consultant at the University Hospital Birmingham, and we have been running our obesity services for a very long time, and I'm going to share some of the experience. These are my disclosures. Now, when it comes to describing obesity, one of the questions that is always asked is, why are we all getting obese? Is it a global problem? What is the primary driver for that? So in my first few slides, I think, Mr. Chair, I've got about 30 minutes. In the first few slides, I'm just going to dwell on some of the concepts behind obesity before we start talking about liraglutide 3 milligrams. So one of the best quotes I have ever found around obesity is by Professor Salim Youssef, who is one of the most eminent cardiologists in the world. And he put it very nicely that obesity is a normal response to an abnormal environment. And what it means? What it really means is that if you actually look at the whole of the human race during its evolution, during all its time, we have always lived in what we call a calorie deficit environment. We've always had to fight to get that food. And the way our bodies are programmed, if you look into it, most of our hormones actually make us hungry and want us to eat. And there are just a couple of hormones in the bodies that actually stop you from eating. So the whole system is against you staying thin. And because in the last 40, 50 years, we have had so many calories around us that even with the best of intentions, so we had Peter Short saying, oh, you should walk, you should run. It is difficult for the humans to do so because the basic DNA of the humans is to eat and become fat. And when you are trying to lose weight, you're fighting against that DNA. And this is something very important to remember. So, and that is one of the reasons. So whenever we talk about obesity, we really forget this thing. And when people are trying, we need to push down our BMI lower and lower. What we need to understand, this is the data from the from obesity, and it actually shows it is a J-shaped curve, which basically means that once your BMI crosses 25, your risk of dying early increases. Similarly, when your BMI falls to less than 18.5, your risk of dying actually increases. So the ideal BMI is a very small spectrum between 18.5 to 25, which is something very difficult for us to maintain. Now let us try to understand what we mean by when we're talking about obesity. So obesity is what I call a harbinger of many diseases. It's a fertile soil that leads you to a lot of conditions, starting from type 2 diabetes. If you're not obese, it's very unlikely that you're going to develop type 2 diabetes, to gastrointestinals, to cancers, to gallstones, to obstructive sleep apnea, cardiovascular risk, dermatological issues, PCOS, and so on and so forth. So once you start getting obese, the risk of not only mortality is increased, but morbidity from multiple disease sources increases. Now, when it comes to weight management and obesity, there are a couple of things we need to understand, and this is something very important. The first important thing is that obesity is a complex disease. It is not something to say that somebody overeats, that's why they are fat. No, it's much more than that. And also, it's very important to understand the difference between obesity and adiposity. The difference in obesity and adiposity is not only the weight you carry or the BMI you have got, but where you carry the weight, where you carry the fat. So if the fat is in the visceral liver, that's bad news, but if it's in the subcutaneous tissues, that is not a bad thing. The second big issue with obesity is that obesity is not recognized by any Ministry of Health globally as a disease. Say, for example, it is like saying that hypertension is not a disease. It is a condition because people eat salt. That's why they have got hypertension. Obesity has to be recognized as a medical condition if we are to have these treatments. Now, although lifestyle is the cornerstone, there is no single bullet because the causes of obesity are different in terms of managing it. Now, currently there are 4 types of obesity, or the theories suggest that. One is the hungry brain. So there's something in the arcuate nucleus that makes a person eat more. So this is derived by the neurotransmitter signaling of the brain. Then second one is the hungry gut. Problems with the gut, be it in the flora or in the absorption that absorbs all the food that is eaten. Thirdly, they are the emotional aspects of obesity. So these are things like overeating. And finally, which is not really understood, is a slow burner. People usually can have a low BMR or basal metabolic rate, which means they need less energy to keep themselves warm. And these are the people who will end up getting fat. So if you have got more brown fat, you will burn what you eat, and therefore you do not get fat. So there is a complexity around obesity. Now, obesity, normally people say obesity does not have any symptoms. I say obesity has a symptom. And the symptom of obesity is hunger. People who get obese, they get very hungry. And it's this interaction between the gut to reduce the hunger and increase satiety from the arcuate nucleus that drives the obesity. Currently, 90% of the people with type 2 diabetes are obese. What are the weight management strategies? Diet, lifestyle is very good, but self-directed lifestyle responders, according to the systemic meta-analysis, is only 5%. Only 5% tend to respond to lifestyle. Then you have got professional things like the Cambridge diet, the direct trial, or the low-calorie diets, which give 600 to 800 calories. Again, the response rate for the direct trial from the National Diabetes Audit data in the UK is only about 10% of the people respond. Medication, and then we are talking about it, and then there is weight loss surgery. So in most patients, the combination of 3 and 4 that we do. Now, traditionally, the number of medications that have been used to manage obesity have been a recipe of disaster. When we started our obesity clinic, we used to use rimonabant. It was banned because it increased the risk of suicides. Then we started sibutramine, which was again very effective, 5-HT receptor agonist. That was also taken away because it increased the risk of cardiovascular disease. We just have orlistat left, but orlistat causes complications, side effects of it, which is really bad because it causes diarrhea and fecal leakage, which is an extremely unpleasant. And there are other drugs. These are not available in the UK, but in the US, things like naloxone and bupropion, but they are all tend to be centrally acting. So currently, the most promising agents that have been shown are the GLP-1 agonist. In the UK, the only licensed drug, which I get the same in Egypt as well, is liraglutide 3 milligrams or Saxenda that is available. Now let us try to examine the GLP-1s and see how they act. I think this part you probably know. I'm going to look at the brain element of it. And the main brain element of it, which is quite important, is its effect on the arcuate nucleus in terms of increasing satiety, which actually stops one from eating, along with the other effects. So why do GLP-1 analogs act? So as we know, there is the endogenous GLP-1 that is secreted in the gut, and the DPP-4 inhibitors actually inhibit the DPP-4 enzyme that degrades the GLP-1. So the endogenous GLP-1 helps to control the secretion of insulin from the pancreas and decreasing the glucagon. But it hardly has an effect on gastric emptying. This is the physiological level of GLP-1. The pharmacological levels of GLP-1 that are used are much, much higher. And it is in these levels you start seeing decreased appetite, decreased food intake, along with these side effects. So one of the things that you've got to understand is the endogenous GLP-1 doesn't make you lose weight with DPP-4, and the GLP-1s actually do it. And this was actually shown in the initial studies in rats, which showed that giving liraglutide actually reduces the food intake and reduces the weight gain in rats. Now we're going to look specifically at liraglutide 3 milligrams and see what the benefits of these drugs are. One of the first things, as I mentioned to you, is to understand what drives the appetite. So you've got the GABA, GLP-1, POMC, and the arcuate nucleus. And what we find is the liraglutide acts both here, which drives the hunger, as well as the arcuate nucleus, which drives the satiety. So it decreases hunger and it improves the satiety. And this has actually been shown in this very interesting study with liraglutide 3 milligrams, which showed that the satiety is increased, the hunger is decreased, fullness is decreased, and prospective food consumption is reduced. So it has multiple effects in terms of reducing the calorie intake, and that is one of the main reasons it drives weight loss. So we looked at the concepts of obesity, looked at the issues around obesity, looked at the challenges. Now let's look at some of the clinical trial data. Now, liraglutide 3 milligrams has been studied in various populations in a well-conducted study. So this was called the SCALE program. We are part of some of these studies, and this is the basic design of these studies were nearly the same. So this is the SCALE obesity and prediabetes study, which looked at the efficacy of 3 milligrams of liraglutide after 160 weeks of treatment in delaying the onset of type 2 diabetes. So it was 1:1 randomization. The inclusion criteria were age greater than 18, stable body weight, BMI greater than 30. And the patients were randomized to either liraglutide 3 milligrams and the placebo, and this was basically looking at how many of them don't go on to develop diabetes. Along with it, lifestyle intervention was given to all the patients, both in the placebo as well in the treatment arm, and this included a hypercaloric diet, 500 kilocalorie diet, along with 150 minutes of physical activity. So what did it show? Now this is something very important to understand, the time of onset of type 2 diabetes and how to interpret. So if we look at this group, this is the difference between the ones who were on placebo and the ones who were on liraglutide. And this is what you would expect. So if you expect in the placebo group, 2% of the population gets diabetes every year, we expected it to take 2.7 years until 2% in the liraglutide group develops, which effectively means that liraglutide 3 milligrams prevents the progression of diabetes from prediabetes by 80%. And this is also shown here, that how many of these patients go back into normal glycemia. So after the direct trial, we have started using the word diabetes remission, which means that their glycemic control is normal, and you can actually start seeing here in the liraglutide group, the percentage is much higher. It goes up to 70% compared to 30% at 28 weeks. But interestingly, even at 160 weeks, 66% of the group patients, of people rather, in the liraglutide group are in the normal glycemia compared to 33% here. And what about weight loss? That's the one thing that is driving it. So the average weight loss you get with liraglutide is around 9 kilograms. But actually, if you look into what we call the placebo-subtracted weight loss, it comes to about 8 kilograms, which is highly statistically significant. Now, this is something which I see a lot in my clinic. So we've got one of the largest obesity clinic, and I see a number of the patients. So when I see my patients with obesity and I'm starting them on Saxenda, they ask a lot of questions. How much weight will I lose weight, or will I not lose the weight? If you actually look at the evidence with GLP-1s and Saxenda in particular, what you find is that 2/3 of the patients will lose weight and a third of patients on GLP-1s will not lose weight. It is very difficult to predict which are the third that will not lose weight. But among the 2/3 that will lose weight, a third will lose an amazing amount of weight. You're talking about 15 kilograms, 20 kilograms. These are the ones that will put your picture on Twitter or social media that they have lost this weight. A third of the patients will lose a good amount of weight, which is about 8 to 10, but a third will not lose weight. We'll try to see how we can identify the patients who will lose that weight so that your 2/3 are identified. So if you look by the EMA criteria, which is about 5 to 10% weight loss, you'll find nearly 67% of them in the liraglutide will be responding. So what is the indicator that actually shows you that these are the patients that are going to lose weight? So this is what I call early responders. So always the early responders are the good responders. So the patients who start losing your weight between 4 and 6 weeks, even if there is a small drop in weight, you will find that these are the patients who will really lose about 11 to 12% of the body weight. Compared to the ones who respond slowly, these are the ones who will only lose about 3% of the body weight. So always remember, when you use Saxenda, early responders are good responders. So some of my patients who respond early with Saxenda, even if they have side effects, I keep persisting with them to continue taking because there are beneficial effects. We also know with other GLP-1s, there is a reduction in blood pressure, which is, again, as you know, contributes to decreasing cardiovascular mortality. And also a change in the liver profile, especially with decrease in total cholesterol and a big decrease in the VLDL cholesterols and triglycerides. And if you're looking for the surrogate cardiovascular markers, be it high sensitivity CRP, is decreased and adiponectin is increased. Now, this was in prediabetes. Now, let's look at what happens in people in type 2 diabetes and obesity. So these are our patients who've got diabetes and obesity. So this is again a part of the scale diabetes trial. Again, looking at the efficacy, BMI 27, HbA1c is between 7 and 10, treated with diabetes medication. Again, 3 arms of the study: placebo, liraglutide 1.8, and liraglutide 3 milligrams. Similar lifestyle advice. And this is what we see. Again, weight loss. So people with type 2 diabetes, as you know, because of the medication and for other reasons, cannot lose weight. But again, you're getting a weight loss of nearly 9.3 kilograms. And if you look at the change in the HbA1c, we are looking at a reduction of nearly 1.3%. So the one difference that again I try to emphasize between Victoza 1.8 and Saxenda 3 milligrams is, in terms of the HbA1c, the change is not much. It's 1.1 and 1.3, only 0.2% decrease. But the big change is in weight. So if you want bigger weight loss, you need the higher dose. And that is probably true for most GLP-1s. Similarly, fasting plasma glucose levels also come down quite well. And this is the percentage of populations on reaching the HbA1c target, and as you could see, it's nearly 65-70%, which is quite high. Now, one of the main things that I'm asked by a number of patients and a number of other colleagues when I speak about these agents is, you say these agents make you lose weight, but where are we losing weight? I think early on, Professor Hastein was talking about sarcopenia. So in some of my patients, who, especially in the elderly ones, I want them to lose weight, but I don't want them to lose muscle mass. So we really want to understand where this weight loss is doing. So this is a very nice, decent study, basically trying to look out where the weight loss happens with Saxenda in terms of visceral and ectopic fat. So there were 185 participants, again very similar criteria. They should have all been on MRI, and they had a run-in period of less than 500 and increased physical activity. 1:1 liraglutide and lifestyle, and the key endpoints was the primary percentage reduction in visceral adipose tissue, and this was measured with the MRI in week 40. Along with it, a number of other things in terms of change in weight, liver fat percent, and metabolic biomarkers were studies. So this is what it showed. So if you look at the overall reduction in visceral adipose tissue, it was nearly 12.5 to 13%. And if you look at the total body adipose tissue, again 9%. In the abdominal subcutaneous adipose tissue, again nearly 10%, and in the lower body adipose tissue, again 10%. All of them highly statistically significant when you compare to placebo. Now this is something which is very important, because one of the concepts of the direct study which showed that it is possible to reverse diabetes by giving people 800 kilocalorie less hypocaloric diet in what we call the total food replacement. One of the big concepts in that program by Roy Taylor was that the reduction, it happens in terms of the liver and the pancreatic fat. Because if you've got diabetes, if you are able to shift just a gram of fat from the pancreas, it has a huge effect in terms of regenerating the beta cells. Similarly, any reduction in the liver fat by about 10% has a huge benefit. So what this study actually showed was reduced liver fat in patients who were overweight and obese, and you find the reduction in the liraglutide of nearly 12.4%. And this is quite significant. Now, one of the other clinics that I'm involved in is we have got a NASH NAFL clinic that we've done at the University Hospital. And we have been involved in a number of clinical trials with various GLP-1 analogs, be it the lean study with liraglutide 1.8, the SEMA-NASH study with semaglutide, and all these have started showing significant reduction in the progression of NAFL. So although there are lots of new treatments coming from NAFL, a number of new novel agents, but currently the ones that are showing the most promise are the GLP-1 analogs. And this reduction in visceral adipose fat is not only confined to this. So in this post hoc analysis across the subgroups, it shows that it works in people less than 50, greater than 50, men, women, white, black, Hispanic, overweight, obese, pre-diabetes or no pre-diabetes. In all the population groups that were there in the study, you could see it. So there is no heterogeneity in terms of its response of reduction. So what we can say, so relative effects of liraglutide on fat reductions were 2 times greater in the abdominal viscera and 6 times greater in the liver, seen on overall body weight measured by MRI. So what are the implications? The implications are reduction of visceral fat and hepatic fat could be a mechanism underpinning the cardiovascular disease risk benefit that has been seen with liraglutide in patients with type 2 diabetes, suggesting that liraglutide may modulate visceral adipose tissue in patients with overweight and obesity at high risk of CVD. So basically saying that probably one of the drivers of the positive cardiovascular effects that you're seeing with liraglutide in studies like LEADER or LEADER is probably being driven by reduction in this visceral adipose tissue. Now this is the LEADER study again showing reduction in cardiovascular death, non-fatal MI, myocardial infarctions or non-fatal by nearly 13%, showing that this works in reducing the cardiovascular disease. This is also very great news because I think in Birmingham, a third of the school-going children are obese, and we reported our first case of type 2 diabetes in about 1999 of an obese type 2 diabetes in an 8-year-old girl in the UK. And now we have got a full clinic of kids who are less than 15 years who are obese and have got type 2 diabetes. And in the US, as you're aware, among children, there's more type 2 than type 1. There was no other treatment available, but now in the Scale Teens Summary Study, it shows that it works in children, which is absolutely great news, and a lot of pediatricians have started using it. This is the pen. I'm sure you have seen it. You start with 0.6 milligram and you increase the dose to 1.8 on a weekly basis. Now, other practical tip which I always give to my patients is, when they're titrating the dose, it is important for them to go to 3 milligrams. But sometimes, say, when they are increasing from 1.8 to 2.4 milligrams and they start having more side effects, they stop the medication. I always tell them, don't stop the medication, go back on 1.8 and continue for a couple of weeks and then titrate to 2.4. So that is something very important for us to remember. So if they stop it, then you kick-start it, you're not going to get the effect. It is about trying to see how you can get the patients to 3 milligrams and maintain them. So, Mr. Chairman, as in my final concluding style, what I can say is Saxenda can help different people living with or without diabetes populations to achieve significant weight loss. Early responders achieve nearly 12%, as I said to you. Early responders are good responders, reduction in the weight in the first year. Saxenda can fit before or after bariatric surgery. I didn't share in my presentation today. We've got a lot of experience of bariatric surgery, especially in my next session. I'm going to be talking about the various types of bariatric surgeries. And in something like gastric band, we tend to use it. And Saxenda is now approved in adolescents from 12 years with same safety profile as adults. Thank you.